There is a condition that can cause strokes in young, otherwise healthy people. It can trigger repeated miscarriages in women with no other obvious explanation. It can cause blood clots in the legs, the lungs, and places doctors do not always think to look first. And in many cases, the person carrying it has no idea it exists until something serious has already happened. What makes it particularly hard to catch is not just what it does, it is how convincingly it pretends to be something else. The symptoms can look like lupus, like multiple sclerosis, like a clotting disorder with no clear cause, like anxiety, like migraine, or like a long list of unrelated problems that happen to share the same body. That is the nature of antiphospholipid syndrome. If you have never heard of it, or if you have heard the name but never quite grasped what it means, you are far from alone. Even experienced physicians can overlook it, not because they are not paying attention, but because this condition is genuinely one of the most deceptive in modern medicine. This video is going to break it down clearly. What antiphospholipid syndrome actually is, what it does inside the body, why it so often gets mistaken for something else, what signs may matter most, and what you should understand if this condition has come up in your life or the life of someone you care about. This is not a video designed to frighten you. It is designed to give you clarity because with antiphospholipid syndrome, understanding it clearly may matter more than you think. So what exactly is it? Your blood has a built-in clotting system. When you cut yourself, your body sends signals that thicken the blood and seal the wound. That is supposed to happen. The problem in antiphospholipid syndrome is that this system fires when it should not. It activates inside blood vessels without any wound to seal, without any injury to repair. And when clots form where they have no business forming, the consequences can be serious. The reason comes down to the immune system. In antiphospholipid syndrome, the immune system produces proteins called antiphospholipid antibodies. Normally, antibodies are the body's defense team. They identify and target threats like bacteria and viruses. But here, the immune system makes a significant error. It starts producing antibodies that attack certain proteins in the body's own blood, proteins involved in normal clotting regulation. When those antibodies interfere, the clotting balance breaks down. Blood becomes more likely to clot than it should be, in places it should not, at times when the body has no need for it. This is what doctors mean when they call antiphospholipid syndrome an autoimmune condition. The body is not fighting an outside invader. It is turning against its own systems. And because blood travels everywhere, the consequences of that misdirected response can show up in almost any part of the body. One more thing worth clarifying early on. Some people carry antiphospholipid antibodies without ever developing the clinical problems the syndrome causes. Having antibodies on a single test is not the same as having the full syndrome. Doctors generally look for antibodies to appear on more than one occasion, at least 12 weeks apart, alongside actual clinical events like clots or pregnancy complications. That distinction matters because it shapes how the condition is understood, evaluated, and managed. Antiphospholipid syndrome can appear on its own, sometimes called primary antiphospholipid syndrome, or it can appear alongside another autoimmune condition, most often lupus, in which case it is sometimes called secondary. Either way, the core problem is the same. The blood clots more easily than it should, and that tendency can create serious consequences across multiple body systems. The symptoms do not arrive with a label. They do not announce themselves as part of one unified condition. They show up scattered, sometimes years apart, in different parts of the body, each one feeling completely unrelated to the last. That scattered presentation is exactly why so many cases go unrecognized for so long. The most familiar consequence is abnormal blood clotting. But where those clots form and what they cause can vary significantly from one person to the next, which is one of the central reasons this syndrome mimics so many other conditions so convincingly. When a clot forms in a deep vein, usually in the leg, it can cause swelling, pain, warmth, and redness. On its own, that might be attributed to long periods of sitting, dehydration, or other common causes. Without the broader picture, antiphospholipid syndrome may not enter the conversation at all. When a clot reaches the lungs, it becomes a pulmonary embolism, producing sudden shortness of breath, chest pain, a rapid heart rate, and in serious cases, a life-threatening emergency. Again, without a fuller history, the syndrome driving the clot may be missed entirely. When clotting affects the brain, it can cause a stroke or a transient ischemic attack, sometimes called a mini-stroke. This is one of the more alarming presentations, particularly because strokes connected to this syndrome often affect people who are young. A stroke in someone in their 20s or 30s with no obvious cardiac risk factors, no high blood pressure, no history of smoking, can be one of the first visible signs that antiphospholipid syndrome is present. Even then, it is not always the first thing investigated. The syndrome can also show up on the skin. Some people develop a pattern called livido reticularis, a mottled, net-like purplish discoloration, often on the legs or arms. It can look like a bruising pattern or a circulation quirk, and many people who have had it for years never connect it to an underlying autoimmune condition. It gets especially easy to dismiss in cold weather, when the pattern becomes more pronounced. Migraines are another frequent feature, and among the most overlooked. Since migraine is common in the general population, when someone with undiagnosed antiphospholipid syndrome starts getting frequent or severe ones, there is rarely an immediate reason to suspect an autoimmune clotting condition. The migraines get treated as migraines. The syndrome continues undetected. Some people experience cognitive symptoms as well. Difficulty concentrating, memory lapses, mental fog, a sense that thinking feels slower than it used to. These can be subtle in early stages and are often attributed to stress, poor sleep, or anxiety. They may occasionally prompt neurological investigation, but antiphospholipid syndrome may still not be the first condition considered. Heart involvement is possible too. Some people develop problems with the heart valves, a condition called Liebman-Sachs endocarditis, involving thickening or small growths on valve surfaces. This can affect how the heart functions and may increase stroke risk further, another layer of cardiovascular complexity the syndrome can quietly introduce over time. And then there is the pregnancy dimension, which for many women is the first moment antiphospholipid syndrome enters the picture at all. Recurrent pregnancy loss is one of the syndrome's most recognized features. Women who experience multiple miscarriages, particularly in the second trimester or later, may eventually be tested for antiphospholipid antibodies. The syndrome can interfere with placental development, reducing blood flow to the baby and increasing the risk of complications, including preeclampsia, which involves dangerous blood pressure elevations during pregnancy, as well as preterm birth and fetal growth restriction. For women who have been through repeated unexplained losses, a diagnosis of antiphospholipid syndrome can be both devastating and, in a complicated way, clarifying. It gives a name to something that had none. And it opens a path toward management that may improve future outcomes. What connects all of these manifestations is the blood. The clotting tendency does not stay in one place. It can appear wherever blood flows, which is everywhere. That is why this syndrome can look so different from one person to the next, and why it so often gets mistaken for a collection of separate, unrelated problems rather than one unified underlying condition. If there is one word that follows antiphospholipid syndrome more consistently than almost any other, it is delay. Delay in recognition, delay in testing, delay in diagnosis. Understanding why that delay happens is not about finding fault. It is about understanding the genuine complexity this syndrome presents, both to the people living with it and to the clinicians trying to make sense of it. The first reason diagnosis gets delayed is the one already touched on. Symptoms do not arrive together. They come separately, sometimes years apart in different body systems, each one seemingly explainable on its own. A migraine is a migraine. A miscarriage is a miscarriage. A clot in the leg after a long flight is a clot in the leg after a long flight. Each event gets evaluated and treated in isolation. Without someone stepping back to see the pattern across time, the thread connecting them may never get pulled. This is especially true when the person affected is otherwise young and healthy. Medicine tends to think about serious clotting and autoimmune disorders in terms of risk profiles. Older patients, patients with known risk factors, patients with complex histories. When a young person presents with a single clotting event or neurological symptom, the instinct is usually to look for the simplest explanation first. That is not unreasonable medicine, but it can leave antiphospholipid syndrome off the radar longer than it should be. The second reason misdiagnosis happens is significant overlap with better-known conditions. Lupus is one of the most important examples. A meaningful number of people with lupus also carry antiphospholipid antibodies. and the symptoms of the two conditions overlap considerably. Joint pain, fatigue, skin changes, and immune system involvement appear in both. When someone is already being managed for lupus, new symptoms may get attributed to the lupus rather than prompting a separate investigation. Multiple sclerosis is another condition antiphospholipid syndrome can convincingly resemble. The cognitive symptoms, neurological changes, episodes of dysfunction that come and go, these can look remarkably similar on the surface. There are documented cases of people diagnosed with multiple sclerosis who were later found to have antiphospholipid syndrome instead or alongside it. The two conditions are different, but the symptom overlap can be real enough to create genuine diagnostic confusion. Fibromyalgia and chronic fatigue syndrome have also been applied to people whose underlying problem was antiphospholipid syndrome. The fatigue, cognitive fog, diffuse pain, the sense that something systemic is wrong without a clear explanation, these appear in all of these conditions. When blood tests come back without obvious abnormalities and imaging looks unremarkable, the pull toward a functional or pain-related diagnosis can be strong. In some cases, that label gets applied before the specific antibody testing that would reveal antiphospholipid syndrome has even been ordered. Anxiety and depression have entered the picture for some patients as well, not because those conditions are not real, but because some of the neurological symptoms of antiphospholipid syndrome, the brain fog, the difficulty concentrating, the emotional dysregulation that can follow neurological involvement, can be read through a psychological lens rather than an autoimmune one. Some patients spend considerable time in mental health treatment before anyone thinks to investigate whether a physical syndrome might be contributing. There is also the issue of the antibodies themselves behaving inconsistently. Antiphospholipid antibodies can fluctuate. They can be present at significant levels one month and lower levels another. If someone happens to be tested during a lower period, the result may not look as concerning as it truly is. That biological variability is one of the reasons the diagnostic criteria require antibodies to be confirmed on more than one occasion, at least 12 weeks apart. A single test is not enough to rule the syndrome in, and may not be enough to rule it out either. What eventually points doctors toward the right answer is usually pattern recognition. A physician who notices that a relatively young patient has had more than one unexplained clotting event. A hematologist who sees recurrent thrombosis without a conventional explanation. An obstetrician who investigates after a third unexplained pregnancy loss. A rheumatologist already treating someone for lupus who thinks to check for antiphospholipid antibodies as part of a broader workup. Sometimes it is the patient who pushes the conversation in the right direction. People who have done their own research, connected their own dots across years of confusing symptoms, and arrived at an appointment with a specific question about antiphospholipid syndrome sometimes play a meaningful role in prompting the testing that leads to their own diagnosis. That is not how medicine should ideally work, but in the real world of a condition this complex and this frequently overlooked, it happens more often than most people realize. The testing, once ordered, involves blood tests looking for three main types of antiphospholipid antibodies: lupus anticoagulant, anticardiolipin antibodies, and anti-beta-2 glycoprotein 1 antibodies. The names are technical, but the principle is straightforward. Doctors are looking for the presence of these misdirected immune proteins and looking for them to persist over time rather than appear as a temporary finding. When persistent antibodies are found alongside a history of clotting events or pregnancy complications, the picture of antiphospholipid syndrome starts to come into focus. The delay in diagnosis is not simply a medical failure. It reflects how genuinely difficult this syndrome is to see clearly when its pieces are scattered across years and body systems. But that difficulty is exactly why awareness matters. The sooner the pattern is recognized, the sooner management that can make a real difference can begin. Understanding what antiphospholipid syndrome is and understanding how it is managed are two different things. For many people who receive this diagnosis, the management question is the most pressing one. What happens now? What does living with this actually mean? What can be done? The honest answer is that antiphospholipid syndrome cannot currently be cured in the way some conditions can. There is no treatment that eliminates the antibodies permanently or resets the immune system's misdirected response. Management focuses instead on reducing the risk those antibodies create, which in practical terms means reducing the risk of dangerous blood clots and the serious events they can cause. For most people diagnosed after a clotting event, management centers on anticoagulation therapy, which is medication that interferes with the clotting process. These medications do not dissolve existing clots immediately, but they reduce the likelihood of new ones forming and give the body more time to manage existing ones. For many years, the most commonly used anticoagulant for antiphospholipid syndrome was warfarin, a medication that has been used in medicine for decades. Warfarin works by interfering with vitamin K, which plays a role in clotting. It is effective, but it requires careful monitoring. The level of anticoagulation it produces can shift with diet, other medications, and individual variation. People taking warfarin typically need regular blood tests to keep their clotting levels within a safe range. Research in recent years has examined whether newer anticoagulant medications, sometimes called direct oral anticoagulants, could be used instead. These are widely used for other clotting conditions and are often more convenient because they require less monitoring. However, the evidence around their use in antiphospholipid syndrome, particularly in patients with what is called triple-positive antibody status, meaning all three main antibody types are present, has raised concerns. Some studies suggest these newer agents may not be as protective in this syndrome as warfarin. Medical guidance in this area continues to evolve, and the right choice depends on the individual's antibody profile, clotting history, and overall health picture. It is an important conversation to have directly with a treating physician. For people who carry antiphospholipid antibodies but have not yet had a clotting event, the approach is more nuanced. Not everyone with the antibodies will develop thrombosis, and long-term anticoagulation carries risks, primarily bleeding. In these cases, doctors may use a lower-intensity approach, sometimes low-dose aspirin, combined with careful monitoring over time. The goal is to balance protection against the risks of treatment itself. For women with antiphospholipid syndrome who are pregnant or planning to become pregnant, management becomes especially important and specialized. Pregnancy naturally increases the tendency of blood to clot, which means the already elevated risk of antiphospholipid syndrome becomes more pronounced during this time. Management typically involves low-dose aspirin and a form of anticoagulation called low molecular weight heparin injected under the skin. It does not cross the placenta in the way some other blood thinners can. With appropriate management, many women with antiphospholipid syndrome go on to have successful pregnancies, which is worth holding on to for anyone who has been through recurrent loss and wonders whether a different outcome is possible. Beyond medication, living with antiphospholipid syndrome means staying aware of everyday situations that raise clotting risk. Long periods of immobility, like extended flights or car journeys, matter more for someone with this syndrome. Dehydration affects blood viscosity. Some hormonal contraceptives that contain estrogen can increase clotting risk and may need to be reconsidered. Smoking compounds cardiovascular risk significantly for anyone, and for someone with this syndrome, the additional risk it creates is not minor. Infections and illness can sometimes trigger flares or periods of increased antibody activity, another reason regular healthcare contact and attentiveness to how the body responds during illness matters. The cognitive and neurological symptoms some people experience with antiphospholipid syndrome deserve their own attention. Brain fog, memory difficulty, and trouble concentrating can affect daily life considerably, even when they do not reach the level of a major neurological event. These symptoms are not always fully resolved by anticoagulation alone. Managing them may involve medical treatment, cognitive support, rest, and adjusting expectations in a practical way. Some people notice that cognitive symptoms fluctuate, better during stable periods, worse during illness or stress. Fatigue is another feature many people describe as one of the most persistently difficult parts of living with this condition. It is not always the kind of tiredness that sleep fixes. It can be a deeper, more systemic exhaustion that requires pacing and planning. For people who were previously active or who carry significant responsibilities, learning to manage energy carefully can require a genuine shift in approach. For those living alongside someone with antiphospholipid syndrome, understanding the invisible nature of many symptoms matters. This is a condition that can look unremarkable from the outside, while creating real difficulty on the inside. The fatigue is real. The cognitive symptoms are real. The anxiety that can come with knowing your blood is prone to dangerous clotting is real. Supporting someone often means holding space for symptoms that are not visible, and understanding that a good day does not mean the condition has gone away. Regular follow-up with a rheumatologist, hematologist, or specialist familiar with antiphospholipid syndrome is part of long-term care. The syndrome requires ongoing monitoring, periodic reassessment of antibody levels and clotting risk, and attentiveness to new symptoms that might signal a change. It is not a diagnosis that can be managed once and set aside. What people with this syndrome often describe as one of the most important shifts is moving from confusion and fear toward informed awareness. That shift does not make the condition disappear, but it changes the relationship a person has with it. Antiphospholipid syndrome does not announce itself loudly. It arrives through symptoms that seem unrelated, through events that get explained away one at a time, through years of confusion that only begin to resolve when someone finally looks at the full picture. That is what makes awareness so genuinely important here. Not vague awareness, but the specific kind that helps a person recognize a pattern, ask a better question, or push a conversation with a doctor in a more useful direction. A few things worth keeping clearly in mind before we close. If you or someone you know has had unexplained blood clots, particularly in a relatively young person without obvious conventional risk factors, antiphospholipid syndrome is worth raising with a doctor. A single clotting event may have a simple explanation. Recurrent events, especially across different parts of the body, are worth looking into more carefully. If you or someone you know has had recurrent pregnancy losses, particularly in the second trimester or later, and has not yet been tested for antiphospholipid antibodies, that conversation is worth having with an obstetrician or a specialist in recurrent pregnancy loss. The connection between this syndrome and pregnancy complications is well established, and management options exist that may meaningfully improve outcomes. If neurological symptoms have appeared without a clear explanation, things like stroke in a young person, recurring mini-strokes, persistent cognitive fog, or unusual headache patterns that have not responded to standard treatment, antiphospholipid syndrome belongs on the list of possibilities to be tested for and ruled in or out. If there is already a diagnosis of lupus or another autoimmune condition and new symptoms involving clotting, circulation, or neurological function are emerging, asking specifically about antiphospholipid antibody testing may be worthwhile. None of this is meant to create alarm. Most people who experience a migraine, a miscarriage, or a clot in the leg do not have antiphospholipid syndrome. These events have many possible explanations, and most of those explanations are not this syndrome. But for the people in whom antiphospholipid syndrome is the underlying cause, the difference between recognizing it and missing it can be profound. What you do not know can hurt you here. What you do know can protect you. Warning signs that should prompt timely medical evaluation include sudden weakness or numbness on one side of the body, sudden difficulty speaking or understanding speech, sudden severe headache with no clear cause, unexplained shortness of breath or chest pain, significant swelling or pain in one leg without injury, and any sudden change in vision. These warrant urgent attention regardless of whether antiphospholipid syndrome is suspected. For someone who already knows they carry this condition, these symptoms carry additional weight and should never be waited out. For those already diagnosed, the most important thing to understand is that this condition is manageable. It requires attention and ongoing medical partnership, and it requires a genuine understanding of your own risk profile. But people live full lives with antiphospholipid syndrome. They work, travel, raise families, build careers. Management is not a guarantee against every risk, but it is a real and meaningful tool for reducing the most serious ones. Learning that your immune system is working against you in a way that raises the risk of strokes and clots is not a small thing to absorb. It can bring fear, grief, and uncertainty. Those feelings are legitimate. They also tend to become more manageable as understanding deepens. Fear shrinks when confusion is replaced by clarity. That is one of the quieter benefits of actually understanding what a condition is, rather than living in the shadow of a name that never quite made sense. Antiphospholipid syndrome mimics others. It hides behind individual events. It challenges experienced clinicians, but it can be identified, it can be managed, and it does not have to define the life of the person who carries it. If this explanation helped you understand something you had been confused about, or gave language to something you have been trying to describe to a doctor, or simply made a complicated syndrome feel a little less overwhelming, then it did what it was meant to do. If there is a syndrome you have been trying to understand, or one you think deserves a clearer explanation than what you have found so far, leave it in the comments. And if any part of today's explanation raised a specific question for you about a symptom, a term, or something you want to understand more deeply, ask that too. No question about a syndrome is too small to deserve a clear answer.